we'll start off with the deciduous dentition and see if I can remember this. This is the usual sequence in the deciduous dentition, going from 6 months to 30 months. They always talk about the deciduous dentition as being ovoid, like that. But the deal is the ovoidness goes away when you add molars like that. And the ovoid turns into a catenary curve, which is a catenary curve is a hanging chain curve. We have, let me see here. I'm going to see what I'm going to say. We have spacing about 4 millimeters in the upper arch and 3 millimeters in the lower arch. And this, in the deciduous dentition, this spacing, part of it tends to be concentrated. If we have, and this is mesial. Mesial to the upper canine, distal to the lower canine is a little extra part of this generalized spacing, and these spaces are called the primate spaces because they're reminiscent of the dentition of pan troglodytes or whatever. There's really not an awful lot more to say about this, especially from my standpoint, because in truth I don't know an awful lot more about this. The one thing you need to know, one more thing, is when the first molars come in, that's the end of the deciduous dentition. We're off into the mixed dentition, and the big deal here is if these are and this is distal, and these are second deciduous molars. That's not a very good D. That's the occlusal plane. Then the distal surfaces of the E's are called the terminal planes. And the deal with the terminal planes is they're a property of the second deciduous molars, but their importance is that they are the things that guide the first permanent molars into occlusion. And the relationship of the upper terminal plane and the lower terminal plane determines whether or not the first molars erupt into a class 2, whether they erupt into a class 1, and to be pedantic here, we talk about a class 1, but a class 1 is a malocclusion according to Angle. They could erupt into a normal occlusion, but we don't use that term anymore. But sort of in your mind, when you say, I'm trying to get a class 1, in your mind it should be kind of in quotes, because you're not trying to get a malocclusion, you're trying to get a normal occlusion. But anyway, that's about all there is to it. My apologies for the Palmer notation, because I can't understand the New International. I never know what tooth 978 is or something like that. I just can't figure it out. So I just stay with this. So that's all I want to say about the primary dentition. But now let's go over to the mixed dentition. And what I plan to do today is to tell you about the development of occlusion, and then tell you after that about the space, what the normal factors of occlusal development do to the space available. Because the perimeter, the space available, is like your wages. It determines, your wages determine what you could buy. The space available determines what you can do. Because you got a lot of things you got to do with the space. You got to get the teeth in, blah, 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 blah. So, okay, we'll put this up. One thing, you don't have to do this with PowerPoint, but what can I say? The mixed dead tissue. Now, going back to what I had on here before, the molars come in. It's worth pointing out here, especially in the mandible, that this is all the space you got, and it's all the space you're ever going to get, unless you decide to blow everything forward. Because there are no sutures in the mandible, nothing you can split. There's a tendency, the anterior component of force, interproximal caries. There's a tendency for the molars to come forward. The start of the mixed dentition, these come forward, so the space you got then, especially in the mandible, that space or less is all you're ever going to have. Okay. Oh, Jesus. There we go. So this is the space that we have. This space must accommodate the incisors, the canines, and the bicuspids. Let's see how I want to do this. Okay. Let me make sure I get this right. In other words, the size of the deciduous teeth is roughly the same as the size of the teeth that will replace them. However, there's one tiny little problem. We have a problem, even though overall the size of the deciduous teeth is probably about the same as the permanent teeth, but there's a division. C plus D plus E is much bigger than 3 plus 4 plus 5, and A plus B, the incisors, are much smaller. The deciduous incisors are much smaller than the permanent incisors that will replace them. I see here. This excess of the deciduous teeth is called the leeway space. And there's various estimates of this. If you go to Moyer's textbook, and he, of course, used to be the honcho here, or here, just a, per quadrant, Moyer's is estimated that the leeway space, the extra space, is about 1.3 millimeters in the upper arch and 3.1 millimeters in the lower arch. This difference here, the fact that the deciduous incisors are so much smaller than the permanent incisors, this is called the incisor liability. And so the real deal is, how do we get from here to a nice class 1, quote, dentition? So, I'm going to put up something, and this is going to take me a couple minutes, but I'm going to put up the sequence for the permanent dentition. This is the most common sequence. It is a favorable sequence, and I hope that it's something that will help you from day to day and also help you when it comes time to take the boards. So, you can see, and I'm going to, well, here, we'll put in the age here. On average, what age do the 6-year molars come in?
6 years old.
Okay, we're getting there. Roughly what age do the 12-year molars come in? Yep. Now, right here, nothing much happens. Age 9, nothing much happens. So if you remember that, essentially after we get there, when we come over to here, the problem is, how do we get the canines and premolars in? Because once the first molars come in, once the incisors come in, then the space is pretty much fixed in the mandible. In the maxilla, you can move things back. So we'll put in the other. This is not. So there you've got the sequence, and what I will do here is get myself another one of these. And each of these areas has a problem, or each of these areas has to be thought of. We have to talk about the molars. How do the molars get into occlusion? Then we have to talk about the incisors. Then, see how I want to break this up. And I'm numbering that 3. Now, the deal is, if those of you who are farmers, you know that if Mama Pig has one too many offspring, that one pig is short of a source of nutrition. And you'll notice once the molars and the incisors are in, then we got a problem. The first 2 teeth to come in there probably will have no problem at all. It's the third tooth that's going to be a problem. 4, 5, 3, 4, no problem. There's usually enough space. It's these guys that are a problem, and I'm going to call that 5 and 4. And if I have time, I'll talk. That's an eye looking at those. I'll look at second molars and maybe even third molars. But now we can go on and we can look at these. Okay, number 1. This is an occlusal plane, and these are the terminal planes. and this will be distal. So now I need a little more space here. Put in some other oh, jeez. Sorry about that. Now, this is what's called a distal step. This arrangement is a flush terminal plane, and this is the most common in our population. And then we have see here, distal, okay. And this is a so-called mesial step. Now the question is, let me label this. When the first permanent molars erupt here, they will be guided into occlusion. What kind of occlusion will occur if we have a distal step of the second deciduous molars? A class 2, because it guides them in. We have a class 2. What? Oh, I didn't tell you what this is. This is called a mesial step. What would the first molars come in if it was a mesial step? Class 1. Yeah, quote in your mind. This would come in. Okay. The most common, however, is a flush terminal plane. What would the first permanent molars, how would they come in? What?
End on.
Yes, they'd come in end on. So you know that's end on. Well, I didn't exactly get that end on, but just to be a little more precise. Yeah. End on. If they come in class 1, mesial step, the ball game is over. Nothing more to say. If they come in, and I'm talking here about just normal development. If you do nothing, if you just sit back and watch. If it's a distal step, it's all over. Socked in class 2, no problem. Here, however, is that the end of the story there?
No.
No. So this is actually 1A and 1B. And we have to go back to that because the fate of the molars in our population, most commonly with a flush terminal plane, something else has to happen. So we'll go on. We'll get to that a little bit later. Okay. Well, here, so you know where we are. I'll do this. We have handled 1A. But now we've got to deal with the incisors. And specifically with the incisors, we have to figure out how to deal with the incisor liability. In other words, how can little tiny teeth be replaced by pretty big teeth? So, get rid of this here. While I'm doing this, you can talk among yourself, as the old joke goes. Okay. Okay, what could we do to provide enough space, or what would nature do? I'm not asking you to do anything. What would nature do to deal with that incisor liability?
The primate space? Does that help?
Maybe, we'll get to that.
They grow in crooked.
What?
They grow in crooked.
Yeah, growing in crooked would be no problem at all. What's the first thing you might think of that the permanent incisors might do? What?
Erect lingual.
Lingual, there'd be less space.
Maybe.
You broke the code. They can flare. So we can flare. For example, if you know from your cephalometrics, deciduous incisors are pretty much upright. And the permanent incisors are flared. Not that much, but they're flared. And that brings up extra space. So flaring. What else? I heard it before. I heard it through the grapevine. Where could they actually get some space? I heard it over here. Primate space. So we've got the primate space. No, I'm sorry. We've got the generalized spacing. Of which the primate spaces are a part. So if we look, oh Jesus, my wife will not be happy. I usually come back from these with just marks all over. In fact, when I go, she said, be careful of that tie, be careful of that shirt. But anyway, we just won't tell her. If we look at, I showed you, this is, and this is, we'll say this is mesial. Okay, in the upper arch, they can use the primate space directly. They just erupt into it. Down below, primate space is here, and down below in the mandibular arch, deciduous teeth are usually sort of worn off and flat, but somehow they have to be driven, the canines have to be driven back into the primate space. That's why, for example, pediatric, do you retain space for deciduous first molar? You say yes? Okay. The answer is probably no, but I like the answer yes. So here are the molars, like that, and here's, okay, and that's where D is. Okay, some people would put on, they wouldn't do that. I'll make this. Put on a space maintainer that looked like that. What would be wrong with that? What would be wrong with doing that? This is E, this is 6, and that's where D was. What would be wrong with that kind of space maintainer?
You lose the C before you lose the E.
Yeah, maybe. But let's pretend that they're there. Let's pretend that they're immortal. Let's pretend that you lose nothing. What would be wrong with that?
You don't allow the C to dissipate.
Exactly. That, in other words, if you put on a space maintainer like that, you're saying, Mrs. Jones, for only $1,600, we're going to make sure, we're going to make absolutely certain that you have crowding. So the deal is, because you have to be able to push the C's distally into the primate space, then the deal is, if you were to hold space for D, then you would put in a lingual arch wire like that, which would hold the space and at the same time allow the canines to be driven distally. Supposedly the first clue to impending problems is crowding of the deciduous incisors, and if we move forward, yeah, so we've got the incisors in. Okay, so now I'll show you what we have there. We have that, and as I said before, that's the space that has to accommodate the permanent canines and premolars. That would be interesting to be able to predict. I will show you an easy way of doing it. If you take the right lateral and the left central, and you add 11, you've got the 75th percentile of upper 3, 4, 5. If you add 10 and a half, you have of lower 3, 4, 5. So if you find that you want to, planning mixed dentition treatments, this is a really quick way of deciding whether or not there's going to be enough space. But remember, this is the 75th percentile. So this paper that I wrote about that has become the magic paper for the third world. In fact, I found a couple of papers just recently. They check out whether this method works in southern Sudan. And they just say, oh, it overpredicts. Well, they haven't bothered to read the paper. It's been tried with almost every population in the world. They all say it overpredicts because it's supposed to overpredict. You're supposed to use the 75th percentile, which means that you will be more often happily surprised than unhappily surprised. So anyway, we've got that. We know how the incisor liability is going to be taken care of. Flaring using the primate space, specifically the generalized spacing, specifically the primate space. Okay. Let me see what I want to get rid of here. We got 2, okay. Okay, we go on to green is someplace. Oh yeah, here we go. We've done this, We've done this. And now we go on to problem 3. Do you think upper 4, 5, lower 3, 4, do you think that'd be much of a problem, usually? I saw it. No, probably not. I mean, it could be, but generally there's enough space. You'd sort of like, let me see, make sure. You would like the lower canine in before the lower first bicuspid, and this is sort of a big area of discussion, and that is, can an erupting tooth push other teeth around? Now the idea here is, they say get 3 in before 4, so that 3 can support the lower incisors, keep them from going lingually, everything like that, because you want the lower incisors to support the upper incisors, and to support them, you got the canine. And the worry is that if 4 comes in first, it'll push things forward. In other words, if 4 comes in first, this will be maybe blocked out, in which case the lower incisors will go lingually, you get the lips under it, et cetera, et cetera, et cetera. So that's about the only thing. Unless, whatever the eruption sequence is, the first 2 in each quadrant probably are not going to be much of a problem. Let me see here. Oh, one more thing. Up above, oh, Jesus, story about that. Now, this is where the argument really comes in. And the question is, up here, if 7 comes in before 5, can the eruption of 7 push everything forward and block out 5? My guess is that the eruption, and this is just a guess, the eruption, teeth erupting, probably has very little impact on the teeth in front of them. Very little impact. But anyway, we'll see. So let's go to 5. So let's draw ourselves some incisors. So when the canines come down, the upper incisors flare. What's that stage called? The ugly duckling stage. Okay. What are you supposed to do about this flaring? Mrs. Jones comes in, I'm really concerned about my kids' teeth. They're flared, there's a space. What do you do about it? Say it louder. You do nothing. You do nothing. Because what's going to happen is they're going to go like that. It's a normal thing. But let's say you got a car payment coming due. And so you decide you're going to help them out. What would be wrong with, say, taking an elastic, putting around it like that? What would be wrong with that?
Slide it through.
What?
You'll kick the roots out.
Yes, but before that, before it can kick the roots out, the teeth will be gone. Why?
Slide up under the gums.
That's right. If you have a patient who's had radiation therapy and you need to extract a tooth, usually extracting a tooth will cause osteoradionecrosis. So the way you extract teeth in these people is you put rubber bands around. Because the deal is, there's nothing really all that bad about the rubber band except when they forget it. Did I put my rubber band? Oh, I need to put another one. It's called automatism. Old folks my age say, I need to take my pills. Take the pills. What was I going to do? Oh, take my pills. Oh, what was I going to do? Take my pills. It's called automatism, and you probably end up killing yourself. In this case, if you forget the elastics, they will go up like that and extract the tooth. Okay, you guys are smart. You're going to bond on a bracket. Going to do something like this, and you're going to figure eight, something like that, to pull them together. What's wrong with that? Say it.
You'll kick the roots out this too.
You'll kick the roots out, and maybe the canines will chop off the roots. And you'd be shocked, when you decide to use 2x4s, you'd be shocked the number of orthodontists who do that. And then the lawyers call me and want me to be an expert witness. So the deal is, you let them alone. You let them alone. Now, okay. So we've got, That's why I need a minder to go around and tell me where my stuff is. We've gone through this and this. What now do we have to go to in that scheme right there? And I'll tell you, it ain't 7.
4.
What?
1B.
1B. Because these molars are still hanging end to end. They can't be that way forever. They got to go this way or this way. Okay. So now, 1B. Now, this I'm going to tell you is the scheme that you say you believe in when you take boards. When you take boards, here you've got, oh geez, that's a terrible molar. Looks like I'm, and we've got this mesial this way. So the question is, what would you guess the width of a cusp is? Just quick. About 6 to 7. So the deal is, at this stage, we need about a 1 cusp change in the occlusion. So, what do? E's are gone. So when the E's are gone, what happens to the, say, when the upper E is gone, what happens to the upper first molars? They drift forward. And I'll just tell you, probably this forward drift is due to the anterior component of force. The teeth tend to be canted this way, so the occlusion will tend to push them forward. In fact, there was a wonderful experiment that Barentz did. He put a force, he'd put a block between the teeth and had people bite down, and then between, here, I'll just draw this. He put shim stock between the teeth, and he measured how much force it took to pull the shim stock out from between the teeth. Then he would measure how much force it would take to pull out the shim stock when they were biting down on a block. And what he found out was the anterior component of force was measurable, and it actually went around to the other side, at least to the canine. So if you're looking for sort of one of the things that pushes teeth forward, it's probably not erupting third molars, it's just the anterior component of force. But anyway, so these will come forward. According to the semi-lies I've told you, how far on average will the upper molars come forward? On average. What?
1.3 millimeters.
Yeah. In other words, it'll use up the leeway space. So that'll come forward 1.3. And how far forward will the lower molars come forward on average? Okay. Oops. Okay. What's 3.1 minus 1.3? Quick. What? 1.8. So in other words, this, mine's going. 1.8 millimeters. Is that enough to go from end to end to a class, quote, class 1? So the way people usually say, well, yeah, okay, there's something else. What would you guess that people generally say produces the extra millimeter and a half, 2 millimeters of differential between the lower arch and the upper arch? I'm waiting. What? Here's a little kid. There's a little kid. There he is as an adult. What? Yeah, that's the simple thing. They say, well, and this movement here is called now, some of the early people, there was supposedly an early mesial shift before any of the teeth were lost. People don't necessarily believe in that anymore, but they believe in the late mesial shift. And that's what you're supposed to pretend you believe in when you're taking your boards. Just a second. Okay, not too bad. But let me tell you probably a more realistic thing is that the adjustment is a fight between the excess mandibular growth and the mesial movement of the upper molar. And this has been published, so it's not a mystery that's coming out here. And this is the change. If the mandible do I want? No. I think. Oh, I'll show you. I forgot that. If you go to the last 3 pages, the last page, and give me that because I'm forgetting this stuff too. Yeah, here we go. If you go to the, no, not the last page. Yeah, right here. This one right here. It's a battle. Let me go here. Now I go like this. This is the usual thing. You have the mandibular excess, the upper molar movement, and it's just a battle. If the upper molar goes forward more than the mandible outgrows the maxilla, it goes to class 2. If the mandible outgrows the mesial movement of the upper molars, it goes to class 1. In fact, as you go on through your education, you'll find that the secret to correcting malocclusions is controlling the upper dentition. The mandible usually outgrows the maxilla, but we say, well, mandibular growth. But if the teeth are socked in, the other teeth are socked in, and the mandible outgrows the maxilla, they just go forward. So the deal is, we've got to somehow make sure, or if the upper molar mesial movement is less than the mandibular excess, then they'll tend to go to class 1. It's just a battle between the upper jaw, the upper dentition, and mandibular growth. And the nice thing is, you can't make the mandible grow more. It usually will grow more, but you can't make it do that. It will normally do it. And the trick is then, how do you control the upper dentition so that the amount that the mandible grows can actually change the occlusion? So it's a battle between mandibular growth and upper molar mesial movement. But that's not something you put on the board. Okay. Damn it, I wish I could see a clock. Yeah, I got a couple minutes. Let's go. Let's go to the third molars. What are you supposed to do with third molars? What? Okay. When in doubt, take them out. Okay. Now the interesting thing is, that's the idea. And now let's just take a look at this. From an orthodontic and dental standpoint, why would you extract third molars? Yeah, no, just perfect third molars. Perfect third molars. They're coming in perfectly. Why would you want to extract them?
Difficult to clean.
Yeah, operculum and everything. No, but why just does the normal, the unwashed out there, why do they say take out third molars? What? That's why. They're always afraid that the eruption of the third molars is, and I'm just pointing this out, they think it's going to push everything forward. Everything forward, like that. And the interesting thing is, a third molar extraction, I think, is the most expensive surgical procedure. And so, because it's so discrete, from a standpoint of decision theory, it's been examined in great detail. Have you got third molars? Yes? Okay. If you've got third molars, you can either extract or leave them in place. If you extract, there are good things that can happen, and there are bad things that can happen. If you leave them in place, There are good things and there are bad things. And interestingly enough, there's a process called the reference lottery, where you can figure out what value patients place on a certain health state. So in other words, if you extract them as good things, if the bad things, if you break the jaw, if you have paresthesia, everything like that, it is possible to figure out what value or what utility or disutility people would place. So we can figure out the utility and disutility of each of these things. And and this is a patient-centered thing. When you get older and some of you get prostate cancer, can your oncologist tell you how much you would hate to be incontinent? When some of you get breast cancer, can the oncologist tell you how much you should hate to be disfigured, how much you should hate to die, et cetera, et cetera, et cetera? So you can calculate, the utility is something that's each individual. But in any event, they're able to calculate probability times utility is the overall benefit. And what would you guess the final result was? What do you do with third molars? What would you guess? And this is by Tulloch and probably shouldn't even bother to do this because her name is probably not that. So what would you guess they concluded that should be done with third molars? Leave them in place. Let sleeping dogs lie. You extract them only if there's some pathology. If there's no operculum and you're getting inflammation, if there's a tumor, everything like that. Leave them in place. Now the surgeons are having a fit. They're talking about C-reactive protein, and we're just trying to save your life, everything like that. But I'll tell you, yeah, I've got 1 minute.
We have till noon. You have a whole other hour.
Yeah, but I'm meticulous, even though elderly. In 1978, the ADA convened a conference on third molars. And we broke out into various groups. And I was in the group to tell whether or not third molars cause lower incisor crowding. I think it's anterior component of force, but back then, does it cause lower incisor crowding? And we reported to the group that it did not. That night, I was going to dinner, and I went around the corner, and there was the editor of the Oral Surgery Journal. Heavy hitter. And he was surrounded by, and this is a true story, he was surrounded by his acolytes. And as it says in the Western Bible, they were sore afraid. And literally, he raised his hand and silenced and says, "Don't worry, there'll always be third molars to extract. Orthodontists need something to blame their failures on." Oh, hi, Lysle. Daniel Laskin. So that's a tiny problem. Doesn't mean that they're always going to say things that are just financially successful, but C-reactive protein. Anyway, that's sort of a skeleton of occlusal development. Notice, no treatment there. It's sort of a skeleton on which you can hang various kinds of treatment, various approaches. I think now we need about a 5-minute break. No, it's been a good group, 6 minutes. Well, the purpose of this second session, and you need to go to this page, Standards of Occlusal Development, the University of Michigan they have an atlas of standards of changes in dimensions as the occlusion develops. And so the purpose of this is, once again, to tell you what the impact of the steps I told you about occlusal development, what the impact of those steps is on the space. You know, what does it do to the dentition if you don't do anything? And remember, arch perimeter is what you have to work with. It's like your income. It's like your budget. You have to line up the teeth. They have to be in the right angulation. They have to withstand, say, class 2 elastics, class 3 elastics. And so this is what would happen if you did nothing. So, and this is kind of a long trail, but it's good if you have decided, Mrs. Jones, we don't really know. Your incisors are a little crowded, but we'll wait. We'll watch them. Maybe growth will help. This is to disabuse you of that idea. So let's put up here. Arch depth, and that would be and you can see up at the top, you can see the nature, the dimension that I'm talking about. And so arch depth by the way, what does that mean? Yes, I've suppressed 0. If I didn't do that, we'd have to be way down there, and that's bad right there. Okay, and I'm just doing sort of a rough average. This thing breaks down into boys and girls, but okay, what would cause, and oh, I should have said this is maxilla. What would cause arch depth to increase by a couple millimeters during occlusal development? Now, I'm going to ask this question over and over and over again, and pretty much the answer is the same each time. So what would cause an increase in this dimension right here? What? Flaring the incisors. Really simple. And the deal is, that was one of the ways we got enough space. Flaring the incisors a couple millimeters produces 2 millimeters on each side, blah, blah, blah. But that would be flaring. And what would cause a loss? A sudden loss? Around 11 or 12, something like that. What?
Late mesial shift.
There ain't no such thing, really. Well, in a way, you're right. In a way, you're right. Okay. In other words, in some way, the leeway space is used up. So there's the flaring, and there's the leeway space. So in terms of this dimension, it's, what happens is, here, I'll show you. Here. Now that doesn't work with a damn. The incisors go forward. The molars go forward, and so depth is unchanged. Okay? Now, the next one is now, in which arch do you think is the most difficult? Which arch do you have fewer options, more problems, upper or lower? Yep, okay. So in other words, this next one, read it and weep. But remember, the answers are always the same, almost. And this is the mandible. And that'd be about something like that. Okay, what would cause, in the lower arch, an increase in depth of about 1 millimeter? Flaring the incisors. And notice the lower incisors can't really flare as much as the upper incisors, because the lower incisors are constrained by the upper incisors, etc. So that's eruption. What would cause a relatively sudden loss of 3 millimeters in depth?
Loss of the ease.
Exactly. In other words, the leeway space. We wouldn't necessarily call it late mesial shift, but it's a mesial shift to use up the leeway space. So what we've got here is we've got the incisors going forward a little bit, the molars going forward a lot, so that's a big reduction in depth. Okay. Have you noticed they lit up the bell tower here, the Baird Carillon? Does anybody know who Baird was, who gave the Carillon? He was a football coach before fielding Yost. For some reason, he bought it up and gave it to the football coach, gave it to Michigan. Anyway, now, all of that. Perimeter is really important because that's where you line up the teeth. That's where you get them in the right angle. That's where they withstand or they succumb to the pull of class 2 elastics or class 3 elastics. So let's look at the maxilla. That was, okay. And again, 7, 10, no, 14, something like that. What would cause a 4 millimeter increase in perimeter? Okay, but why? How much the upper incisors flare on average? What? So the question is, why would 2 millimeters produce 4 millimeters of perimeter? And this is just a generalized thing that you're going to be told. The idea is that if you flare the teeth, don't have that trouble. Nope. Well, green is gone, and I'm not feeling so well. No. Now, the general idea is that if for every millimeter you flare the incisors, that produces two millimeters on each side. Now, that is a generalization in that if you had an arch form like this, it would be different than an arch form like this. But in general, and that's why people like to dump the lower incisors. Because every millimeter you dump the lower incisors, you pick up a millimeter of space on each side. So this is flaring. Oh, bloody hell. What would cause the sudden loss of space, or loss of perimeter? What? Now, the leeway space is, in general, what in the lower arch? Okay. Some people say 4, but in any event, this is, and I haven't really done it precisely enough, but you might expect it to actually be 4 millimeters. So the question is, why didn't you lose 4 millimeters of space down below? And I'll talk about that a little bit. This is flaring. This is the loss of leeway space. The incisors go forward, the molars go forward, and everybody's happy. Now, we have the mandible. And by the way, this was based on the fact that I was, in a lot of the versions of this, I say 1 millimeter and 2 millimeters for leeway space. And in some places, that's the thing they say. But anyway, let's take a look at mandibular perimeter. Is this going to be good or bad? It's bad. Actually, no, this is right. I said about 2 millimeters. Usually I say about 2 millimeters in the upper arch, 4 millimeters, 3 or 4 millimeters in the lower arch. But now, oh, I love this one. Oh, wait a minute here. Okay, here we have what caused the 2 millimeters of extra perimeter in the lower arch. Flaring of what? By how much?
1 millimeter.
So 1 millimeter, a millimeter on each side, you pick up 2 millimeters. Oh, here's the problem, sport fans. Get out your functional appliances, because here we go. What would cause the loss of 6 millimeters? There ain't but two answers, and you've used up one of them. What's the other one? Yeah, in other words, 3 millimeters aside. And so if it comes forward, that reduces the perimeter by 3 and 3 is 6. So that means that if you're hoping for magic in the mandible, it ain't going to happen. What does this chart there, and I don't want to wander off in this too much, but what kind of treatment does that chart suggest to you?
Lower lingual holding touch.
Ah, okay, what about, yeah, how about I'll make it a loop lingual, and then, oops, up above, so what would you do to get the, see, this isn't going to go forward, so it's not going to help you get a class 1. So what would you do up here? And that goes along with my argument that all treatments of class 2s, all successful treatments of class 2s, whether it was functional, fixed, early, or late, do what they do by controlling the upper dentition. So in this case, you want to treat early, put on a lower lingual and a headgear, or a lower lingual and TADs. Anyway, so this is, that's a lower arch emoji. I think that's what they call them, don't they, you young folks? I loved when my students put stuff on the internet. I loved to troll it. There was a guy from Michigan who graduated from Michigan. He practiced down in Florida, and he's on the internet saying he has discovered that braces are bad. You can't clean your teeth. You cause blah blah blah. And his discovery is Invisalign. He's got an Invisalign practice. And so there was a comment, and I couldn't resist. And my comment was, "Sweet Jesus, pretend that you graduated from North Carolina." But anyway. Actually, this is kind of neat. This is the last time the whiteboard will ever be used. But anyway. Okay, now we need width. And canines and molars. So let's take a look at width changes. And this is going to be inner canine width. And 26, 28, 30. And let's see, I got that about 4 or 5. Well, there's an increase. What would cause, and I suppose I should put, what would cause an increase in width? Maxillary inner canine. Maxillary inner canine. What would cause an increase in width? Please, God. The eruption of the incisors. Because the deal is, if you have canines here and the incisors, oh, that's terrible. The incisors erupt. They push the canines distally into a wider part of the arch. So that's, again, incisor eruption. But what would cause this? Now this is, I'm being naughty here. What would you guess would cause this sudden increase? And there's no way that you can guess. Because you'll notice down here I said canines. I didn't say 3 to 3 because this chart starts at age 4. And the canines at age 4 are little tiny bitty things. And what happens here is, see, as long as they're deciduous canines, and it's like, let's see, like this, the incisors erupt and can push the deciduous, it can use up the leeway space, everything. I mean the primate space. But here is the change from C to 3, and are permanent canines bigger or smaller than deciduous canines? Bigger. And so all this is just the fact that the permanent canines are bigger. And once again, we have our friends, the incisors, erupting. Okay. Now, let's take a look at molars. And now I don't have to be naughty. I can say 6 to 6. And yeah.
Do we get any growth at the palatal suture that contributes to any of that?
Probably. Yes. When you, how far along are you in the facial growth course? Have you done any of Bjork and Skeeler's stuff? But the answer to your question is yes. The palate splits. It splits more posteriorly, and that has an impact on occlusal development. But for someone who only worried about how to make his old British cars run, it's too complex for me right now to talk about. Okay. This one's easy. Okay. We have here plus 4 millimeters in molar width. Now, there used to be an idea about expansion. What would expansion get you? And this was Ricketts' idea, that every millimeter of expansion produces 1 millimeter of perimeter. 4, 5. I forget how that goes. But anyway, the important part is for every millimeter of expansion at the molars, oh yeah, Ricketts said that every millimeter of expansion at the first molars produces 1/4 of a millimeter of space. Therefore, if the molars expand 4 millimeters, what would that do to arch perimeter? 1 millimeter. And so do you remember I said it was 3 and I expected it to be 4? Well, this is where that extra millimeter came from. Expansion of the upper molars. Let's see here. See what else I want to talk about here. Why would you guess the molars would expand? Because just thinking about quickly right now, I said, wait, what am I talking about here? Molars will come forward. That's a problem with this. What would cause molars to expand? And I'm being a little naughty here because you probably haven't got that in facial growth yet. Are both classes taking Dr. Berkman's facial growth? Does he make you feel uncomfortable? Oh, never mind. Anybody seen Full Metal Jacket? You got to see that because there's the drill instructor in Full Metal Jacket. This was a very famous movie, and the first half takes place on Paris Island, and they hired a guy to play the drill instructor, and they decided they needed an actual drill instructor to train this guy, and the actual drill instructor was so good that his screen test was he swore for 15 minutes without ever repeating a swear word while they threw balls at him, tennis balls at him. So R. Lee Ermey, he got the job, and the deal was he would come, the first part of the movie, do I make you angry? Do I make you nervous? Do I frighten you? Well, anyway, if I were to go back, that's the way I'd teach orthodontics. But anyway, if we look at this, let's take a look at a section like this. The upper molars erupt down and out. And you will find out from your facial growth that also there is deposition here, there is deposition on the oral surface, there is resorption on the nasal surface, which brings the palate down, but this outward pattern of eruption is the thing that produces a net increase in intermolar width. Okay. See, I'm being more honest on this one. I'm calling it 3 to 3 rather than K9 to K9. Anyway, and this is and I better put what would cause an increase. Oh, I still should be naughty here. God, I still have to be, because I'm going back early. What would cause mandibular inner canine width to increase? Same answer. Yeah, the eruption in the incisors, because if this is worn off, eruption in the incisors can push the deciduous canines distally, and it pushes them distally into a wider part of the arch. What do you think I was trying to show there, that break?
Stays the same.
What?
It stays the same for a long time.
No, it could have been that. Unfortunately, it wasn't. The switch from C to 3 in the upper arch doesn't really make a difference in terms of width. That's mandibular inner canine. Let me see here. Have any of you ever heard of Fermat's last theorem? He was a mathematician during the Enlightenment, and he had an incredible mathematical hypothesis. And in his book, in his journal, he said, "I've discovered the most wonderful proof, but unfortunately, the margins are too narrow to accept it." It took 400 years and heavy-duty mathematics and heavy-duty computer work to finally prove Fermat's last theorem. Well, this is my version of Fermat's last theorem. And this is one I can't explain. And a few years ago, one of the residents came up with what I thought was a good explanation, which unfortunately I have forgotten. So here it is. And I'll draw this again. This is why I find this confusing. It's in the Michigan Atlas, but remember I drew. Oops, sorry about that. Well, that's good enough. The upper molars erupt like this. If you look at the lower molars, I think they erupt like that. And so my guess is, just if there was nothing else going on here, that the lower intermolar width should decrease. But instead, it increases about 2 millimeters, which should produce, a half a millimeter of extra space, etc. And so I don't know what causes that one. If you can figure out, because it seems to me that it should decrease, just as the path of eruption of the upper molars increases the width. It seems to me that the way the lower molars, I'll make this a little better here, the way the lower molars are set up, that it should decrease. But I don't know why. But what this has given you is what will happen if you do nothing. This is an estimate of the impact of the normal pattern of occlusal development. Oh, by the way, I told you, the deal before about the impact of expansion. The general idea now is the folks in Oklahoma did this. They actually expanded patients and sent them out and brought them back to see what was the impact of expansion, when in fact they could have gone to the Michigan Atlas, taken that drawing and just expanded it like that, and they could have calculated exactly what the folks in Oklahoma came up with. But of course, doing on patients makes it more relevant. But the deal is, the general feeling now, rather than different for canines to molars, is about 3/4 of a millimeter per millimeter of stable expansion. That means if you're going to be an expansion meister and you expect it to be an effective substitute for extraction, that means you better figure out a way of getting 12 to 15 millimeters of stable expansion. Now, just as an aside, there are substitutes for extraction. There's zillions of substitutes for extraction. But I would suggest that maybe you keep on the lookout for an effective substitute for extraction. And an extraction on average picks up, about 8 millimeters, 8.4 millimeters total in the mandibular arch. So if you can figure out something that will pick up 8.4 millimeters in the lower arch, 12 to 15 millimeters expansion, pay attention to that. All these other things are saleable substitutes, but they're not effective substitutes. Anyway, let's see if we got anything else. I think that's about all I can remember. You know, right now I only remember things that are important to me, like how I can make my 2-cylinder Honda start running. It's not a motorcycle, it's actually a car. Any questions? Okay. Have a good lunch.